doing what you do every day. Hopefully this helps you a little bit. I work closely with Dr. Hunter in the Orlando Health System, and we're the Pediatric Level 1 Trauma Center for our area and have been the director for about almost 25 years. We've been providing this service. This should be a little more upbeat than the last one, I hope. I'm a bit of a joker, so we'll have some fun slides. I'm kind of giving an outline what we're going to talk about. We're going to talk about what makes children different, spend some time on the ABCs, and then do some case scenarios and whatnot, which I think is the fun part of the lecture. This is the same lecture that I give. Orange County has a grant for a preceptor academy. So it's a Teach the Teacher where I twice a year teach preceptors in the paramedic community that are going to teach their colleagues. So it's a fairly high level talk, but there's a lot of fun interjected within it. This is just a quick scenario in that medics often get criticized for over-triaging things. I always have to hit my knucklehead partner saying, why is this a trauma alert? Paramedic discretion. But in pediatrics, you really do want to over-triage because you want to get them to a place with the appropriate resources, and sometimes it's hard to assess how severe the children are injured. This is a 3-day-old that fell off a couch. And the mother just brought them into the local ER with the head a little swollen, the baby is crying, no loss of consciousness, no emesis. The only thing concerning is 3-day-olds don't fall off couches. 3-day-olds can be pushed off a couch, they can be dropped off a couch, but they don't really have the physical capability to crawl off a couch. This is the kid's CT scan, and the kid had a big epidural hematoma. So kids have these open sinuses all the way around here, but here's the skull fracture that tore the little bridging artery and caused the epidural. This isn't the same kid, but I thought it was a super cool picture because they left the pacifier in the kid's mouth when they did the CT, and we did the 3D reconstruction. I thought it was a cool picture, so I always collect funny memes and cool pictures. I have no professional disclosures. I like to be outside and anywhere but in the hospital when I don't have to be. So I grew up in Southern California. I really like the mountains and the outdoors, and Florida doesn't have a whole lot of that, so I spent a lot on plane flights. They always ask me to submit my objectives, and it's something really serious that you're going to know the ABCs and know how to triage a patient and whatnot. The bottom line is I hope you have fun, you learn something from this talk, and you kind of carry on some of my passion for trauma care. On the right is kind of how I am on the weekends. As the tequila bottle drains, I start to get a little more fun and exciting. I thought this was always apropos for how my day starts. You wake up, you do something, do nothing, but you always want to just head back to bed. I like this slide because it really points out what the true objectives are as a paramedic or a first-line responder in the community, that you have a very formidable task in front of you. That you're called to a scene, you have a terrified child that you're going to take from their surroundings, you're going to strap them to a backboard, you're going to try to put an IV in them, you might intubate them, who knows. You have a distraught family. And families are always distraught. Sometimes the residents are young and they're very idealistic and whatnot. Like, this mom's being a bitch. I go, you haven't met my wife. Because this is my kid. My wife, who's an ER nurse, would be so far up yours. If our kid's sick, and that's our kid. And we're going to do everything in our power to take care of them. You put them in a traumatic situation, they act up. It's expected. I almost expect it. The other thing is medics aren't always equipped with the right equipment. You all know when you do pediatrics, kind of adults, one size fits all. You bolus a liter, you put them all on the same size backboards. When you do children, you can have a child anywhere from 1 kilo to 100 kilos, and you have to have all the pieces and parts to treat that child, and we don't always have that. I think the bottom one is that children hit very close to home for our first responders and for us. I always tell the residents that the medics downtown, when they go to ORMC with a drunk 25-year-old that got bopped in the head, they kind of power slide into the ER parking lot and let the stretcher roll out and keep going. But when you bring a kid in, the medics are around 30, 40 minutes later saying, hey doc, what did this head CT show? Did we do the right thing, whatnot? We're all aunts, uncles, parents, grandparents. It hits really close to home when it's a kid. And the kids are innocent. The kids usually don't bring this on themselves. They're not drunk. They're usually not doing something stupid till they're teenagers. So it is a tough job for all those involved. A trauma center is really asked to do 4 things in the community: to provide preventative strategies and education, to do acute care, rehabilitation, and research. This talk mainly surrounds the acute care, and that's what most of us do. We cover a pretty big population area, being from Orlando, about 2.5 million people. We have 5 now trauma centers in our 5 level 2 trauma centers. So as a pediatric trauma center, we take children from the level 2s. Now here we're kind of right in the no man's land between two level 1 pediatric trauma centers. So some come to Orlando, most go to Tampa, but either one. But we do get the Central Florida Regional, Osceola Regional, Halifax, and Holmes. The interesting thing of being from this area also is that we have this huge influx of tourists. So not only do we have our population who lives here, but Orlando had 68 million visitors last year, which about a third of those are children. So we kind of have this artificially elevated that it's hard for community planners and whatnot to take into account all those extra people in our area. We really feel it around spring break. We're kind of in a lull right now between spring break and summer, and that lull's up like this week. Orlando Health as a whole sees about 4,600 trauma patients a year. About 700 of those are pediatric, and about 220 of those are full alerts when we see them. We have pretty good statistics. 3% die. Most of them go home. The rehabilitation number is a little artificially low in that we don't have great rehabilitation potential for children, and it's a big economic cost because what you end up doing is taking a parent out of the workforce to stay home and care for that child. So the ability to prevent a pediatric trauma really has an economic impact on the community in that it not only takes away that, if that child's disabled, it takes away their future earning capacity, but it usually takes one of the parents or caregivers out of the workforce as well. We've done much better over the last 20 years. Our mortalities for all the different things we see are going down, no thanks to this knucklehead. He just thought it was pretty cool to put his 3-year-old on a motorbike with no helmet, but we see a lot of that. I like this slide. This reminds me of our typical family showing up in the ER with their baggage, if you know what I mean, and it's like the gypsy family that moves in. But how did we get to these really good statistics in caring for children? And there's a couple things that we've done over the last 20 years that have made a difference. For those of you that have children, this is my favorite slide. I wish I could hard-boil my kids. We went to a graduation. We were all together this weekend. Best night's sleep when your kids are all asleep in your house. Especially once you get to have teenagers and young adults, they're out drinking and carousing, you don't know where they are. So if you could just hard boil them or put them in bubble wrap or something to protect them, that'd be awesome. The parents aren't helping us get here. The parents keep doing stupider and stupider things. This is probably me when I was in college, but this is not me, but it looks like my daughter. This is our typical yuppie mom that drops her kid and can't get off her cell phone long enough to pick them up. Media is not helping. It's too easy for kids to video something stupid and get it out there. When it goes good, it goes good. But when it goes bad, it goes really bad. And we joke when we do our roundtable every morning. We say, did someone get a video of this? Because this would be awesome. And we had one this week. Lit himself on fire, no contingency plan, jumped in a sand pit and rolled around and now has 3rd-degree burns. So it's too easy for them to publicize what they're doing and to get that immediate gratification if it goes well. But those of you as first-line responders know it doesn't always go well. Our politicians aren't helping us. There's been a decrease in funding for EMS over the last 10 years or so. Only 1 in 20 calls is that of a pediatric patient. And pediatrics is costly in that you need additional CEUs and educational courses like this to learn to take care of kids, the appropriate training, and then the cost of all the equipment. So pediatric trauma is a pretty low priority on the politicians' list. Next, I want to kind of go through why kids die and where we can make a difference. So, and this pertains to any trauma patient. So a trauma patient that dies in the first seconds to minutes after an accident, there's nothing we're going to do. Someone who is hit by a car going 100 miles an hour and transects their spinal cord at C1, y'all can be standing there in your truck and I can be standing in the trauma center waiting for him, and we're not going to save that patient. The guy who disrupts his aorta after jumping off a 10th-story building. Those are people that die immediately from either usually a massive cardiovascular or neurologic injury. But what we can do is we can prevent that accident before it happens. So since we can't change the outcome of the event, we have to mold behaviors and whatnot to keep that event from happening. Don't text and drive, click it or ticket, gun safety, all those things, social awareness, behavior modification. That's the only way we're going to change these types of devastating injuries. Where the EMS community has made the biggest strides is in this, is those minutes to hours of getting people to the hospital. You have an epidural hematoma, you're going to do fine. You're going to get to the hospital, you're going to get your CT scan and go right to the operating room and get it evacuated. You don't want to be, who is it, Natasha Lipinski, or the famous actress that was skiing. fell, hit her head, got knocked out, said, I'm okay, I got a headache, I'm going to go lay down for a while. Doesn't wake up, they take her to the local hospital, doesn't have a CAT scanner, they take her to the next hospital in Canada, it's got a CAT scanner, it's got an epidural, and they get to the third hospital where they have a neurosurgeon, she's brain dead. Totally treatable in the state of Florida with our EMS system. Same thing with solid organ injuries, liver, spleen injuries, tension hemopneumothoraxes, pericardial tamponades. These are things that if they're recognized, and now more and more are being recognized in the field, are treatable and survivable with little long-term sequela. So the survival improvement is because we have systematic EMS systems, we have good trauma centers, rapid identification of injuries and treatment. The last group of patients that we're also seeing improvement is those patients that make it to the hospital but then make it home. And those are the really critically ill patients. And again, that starts in the field all the way through their care. And we started looking at things like what were patients dying of a week after an injury, 2 weeks. It was usually infectious complications. It was from a catheter that wasn't put in clean, a central line infection. As a young resident and early attending, I thought every central line that was put in would get infected. It was just a matter of time. And really, that's not the case. A central line, if put in appropriately and maintained appropriately, should never get infected. Catheters should be in and out as soon as possible. And a lot of it starts with sterile technique and whatnot from the minute they hit the door. And we've really seen a diminished amount of ARDS, sepsis, and multi-system organ failure. The other thing is things that work towards rapid mobility, getting people up out of bed, getting people to rehabilitation faster. So our care in the hospital, once the injury, has also improved our survival. The cause of death in children is also kind of age specific. There's a different injury pattern depending on what your response is. And I'm sure you're like I am, if you're responding to a scene and don't know what it is, if it's a 1-year-old, you're starting to think in your mind what kind of injuries it could be, which is different than a 7-year-old, which is different than a 14-year-old. And then when we're sitting there on the receiving end and just know we have a trauma alert coming, we can tell a lot by time of day. 7-year-old, 7 in the morning, hit on the way to school, almost guaranteed. 4 in the afternoon on a Saturday, usually a teenager doing something stupid and the parents been drinking all day. So there's different kind of time of day and age patterns. Infants, you worry about child abuse, suffocation, occasionally motor vehicle trauma, inappropriately restrained in a car seat, or fires. Preschool age, more fires, drowning, and trauma. School age, you get more into bicycle accidents, pedestrian accidents, and then by the time you reach adolescent, it mimics the adult pattern. Motor vehicle accidents, homicides, suicides. Pre-hospital care is important. I just like this slide, and the reason I always throw it in is the picture on your left was a patient brought to me early in my career, and I go, this girl looks fine. Why'd you guys bring it in? And they go, Doc, look at this picture. It took us 30 minutes to get her out of that van, and there was 2 dead people in the car. And then all of a sudden you start going, holy cow, this girl had a, think of the mechanism to do this to this van. Sorry. And it really makes you rethink it. So when the medics bring pictures, I love it because it really resets my think point that this was a legitimate accident. This was serious intrusion in the cabinet and whatnot. The picture on the right was just when I was a fellow in Indiana. It just reminds me of all the house fire. We don't see a lot of this in Florida because of our weather patterns, but those of you that are going to go work in the Northeast and Midwest, every time we got a cold snap, we'd have a space heater fire and kids burnt or smoke inhalation injuries. It was a real common problem. So kind of the objectives for the first responder, the emergency personnel, is to be able to recognize and treat immediately any life-threatening dysfunction, assess the mechanism and extent of injuries, and bring that back to the hospital and give us a good report so they can help us. Document pertinent medical data. I've had my butt saved more than once by a medic that documented a neurologic impairment that I just glanced over. You get the kid to the ICU and the legs aren't moving. You're like, oh crap, and you go back on the medic report, legs weren't moving. You're like, yeah, he got my back on that one. And get him to the appropriate level facility. Pre-hospital care, we look for rapid assessment, control and airway. Control airway doesn't mean intubate. It just means have an airway, be able to ventilate and oxygenate the patient. IV access usually isn't necessary. We live in an urban area. Kids get to the hospital so fast that a lot of time doesn't have to be spent on that. IO needles are fine, but in the old days we see kids, and we don't see this hardly any anymore, where they spent 40 minutes in the field trying to start an IV. You could try on the way in and whatnot. Just you get there so fast it doesn't matter. Immobilize appropriately and get them to the right hospital. This is a nice list if you're going to have in your back pocket things that you are able to do to save someone's life. This is kind of your down and dirty backpacker mentality. I don't need a whole lot of equipment to do this, but these are the things that save lives in that minutes to hours period where we really, that golden hour where we really make a difference. The ability to intubate someone, to immobilize their C-spine, to obtain a surgical airway if necessary, just to ventilate somebody. Bag mask valve, king tube, I don't care. If you're ventilating them and you're keeping their sats up, we're good with that. Hemorrhage control, direct pressure, quick clot, tourniquets, vascular access if necessary, chest tube or needle decompressions if you have a tension pneumothorax, and pericardio. Has anybody done a pericardiocentesis in the field? I've been a surgeon for 25 years. I've done like one in the hospital, but I do kids and it's not a very common problem. It's always on the ATLS exam though, like they're gonna see it all the time. Why do kids die from trauma? They lose their airway, they bleed to death, or they have a devastating neurologic injury. But the bottom line, the physiology, why do people die from trauma? Progressive hypoxia, metabolic acidosis at a cell level. The cells aren't getting the nutrients and the oxygenation required to maintain life. So anything we can do to maintain that is going to preserve life. If you arrest in the field from blunt trauma, is a 95+% fatality. And usually, again, those are due to devastating injuries to major vessels. But sometimes it's correctable. Tension pneumothorax and pericardial tamponade is treatable. The emergency response, primary survey, do your ABCs, resuscitate, do your secondary survey, and get them to the right hospital. Now I want to kind of segue into why are kids, this has been kind of generic up to here, but what makes kids different? And why do we have to approach kids a little differently? There are some minor nuances that are important as you care for children, both anatomically, physiologically, and of course psychologically. Children have less fat and they're very elastic. If you fracture a rib in a school age or younger child, their mortality is 40%. Well, grandpa can smoke a cigarette and cough and break a rib. Why are kids dying of this? It's because they have so much cartilage in their ribs that you have to hit them so hard or run over them with something so heavy. By the time you break a rib, you've hurt the lungs, the liver, the spleen, the heart, whatever's underlying the rib. So they have this really pliable skeleton, and the force gets transmitted throughout them. They also have a big body surface area with big heads, so they tend to lose temperature really rapidly. They get cold. As they get cold, they vasoconstrict, they get coagulopathic and whatnot. So that's one more thing to look at. Their physiologic response is unique also, is that kids tend to not get hypotensive early on. They get tachycardic, but the problem with tachycardia is there's a bunch of reasons for tachycardia. So they can be tachycardic because they're hypotensive and they have blood loss. But again, you take a kid and you strap on a backboard and you try to start an IV in them and you immobilize them, their heart rate's going to go up. They're scared. They may hurt. They may have a fractured femur. So there's a lot of reasons for the tachycardia. The problem is they can maintain their blood pressures till they lose about 1/3 of their blood volume and then they bottom out. And by the time they bottom out, you're so far behind the 8 ball, it's oftentimes hard to get them back. The good thing is they have really good strong hearts and whatnot, so you're not going to fluid overload them. So we tend to be very aggressive with fluid resuscitation, especially if we know the mechanism of injury. Short of a devastating head injury and you think that's an isolated injury, we hit them hard with fluids early on. Psychologically, they don't cope well, and we've spoke about that. We try to keep a calm, child-friendly environment, which, if any of you have been in a trauma room during a resuscitation, isn't the most calm, friendly environment, but we try. If they're old enough to understand, I usually go up and talk to them and try to explain to them what we're doing. We do have child life therapy in the trauma room with them. We let their parents in the room, which I was really opposed to at first, but I'm an old curmudgeon. I was like, get them out of here. I let them stay as long as they're appropriate. Now, you guys can have that option too. If they're inappropriate, you don't have to put them in the rig with you and take them. So if they start acting up, thank God we have the chaplains respond to all our alerts. And I have a little nod I do. The chaplain means get them the hell out of here. I look over and go, and they wander over and usher them out. We probably miss a lot of PTSD. We don't do a good job of screening or following these kids up. We see a lot of kids who lose a parent in the accident and know about it. And they're in the car, their parents are crushed in the front seat and whatnot. And we do nothing psychologically. I mean, we have kids that come in and grandma and grandpa come pick them up and take them home. You can imagine you're coming home from Disney and you live in Missouri, next thing you know, grandma and grandpa are flying here to take you home to an empty house. And so we probably should do a better job at following up on that. The primary survey is just like adults. Do your ABCs, go through your secondary survey, and then just keep repeating it. If you're going to transfer the patient out, it's when we do our ATLS scenarios, the class thinking is you do your ABCs in your primary survey, and then something happens. And what they're trying to do is to get you to hone in on something. I always tell the students, go back and start at A and just keep working through it methodically, and you will never, ever miss something. I thought this was cute, too. I won't read it to you. Y'all can kind of figure it out. You got to be in kind of work in emergency service. My brother, the lawyer, doesn't get this at all, but which I'm not sure what he gets other than a lot of money. Anyways, the ABCs are a little bit of it's if they're arrested when you get there. The American Heart Association did go to doing compressions first. Airway, first thing to always look for is just assess the airway. And kids, you got to think obstruction. You just come in, the kid's down in blue. They might have just aspirated something. They got a penny in the back of their mouth or a piece of Lego you can pull out. They can have secretions, foreign bodies, blood, edema. Usually if they have a foreign body, there's some stridor if they're still breathing, that kind of upper airway. You can hear. The airway management can just be supplemental oxygen. You can do a jaw thrust. Some of these, especially little kids, have really big floppy tongues in the anterior airway. And if you just do a little jaw thrust, you open them right up. Intubate if necessary. Surgical airway in kids is rarely needed. Again, we've done a couple of these over the last 20 years. We can always get an airway. Here's another one this is medic humor, when the endotracheal tube's taped at about 3 and just hanging out, and the cuff's he's probably biting on the cuff to pose for this picture. Kids have big tongues, anterior tracheas. The other thing that we see real commonly, it's really easy to do a right main stem intubation, which I have no problem with. If you have an airway, you have an airway. You can easily ventilate and oxygenate someone with a right main stem intubation. In fact, every time we put someone to sleep in the operating room, we almost always get a right main stem. You go through the cords, you put your tube in, and then you start listening to breath sounds, and you back your tube out till you have bilateral breath sounds. Well, that's easy in a well-lit, warm, quiet operating room. It ain't going to happen in a rig or on a busy street with a mother screaming over your shoulder. So the only thing I forewarn is the people in the hospitals. Oftentimes, we had a kid come in the other night, white out of the left chest, everyone's screaming pneumothorax, stop, it's a right main stem intubation, back it out, lung reinflates. It's not a big deal. It happens a lot, and we don't worry about it. Breathing, you want to look for absence of ventilation. Again, hyperresonance, dull to percussion. I'm not doing this in the trauma room. I can't hear anything. When you're a rig and your ambulance or your sirens are going, you're not going to be able to percuss a chest. You're looking to see if the chest moves, doesn't move symmetrically. This is actually a good picture of a what we call a flail chest. Is 2 or more ribs broken in 2 or more planes. So these ribs are broken here and here, and you get this paradoxic motion. That becomes a free-floating piece of rib meat that when you take a big breath, it sucks in, and when you expire, it does the opposite. It bows out, and those are the ones you want to splint. This is just a quick chart to interpret airway sounds. Stridor means upper airway. Wheezing is more distal airway, usually secretions. Crackles can just be some blood. Absent breath sounds, think pneumo or hemothorax. So for breathing, we want adequate ventilation. Doesn't always mean intubation. Oxygen saturation and tidal. Look for breath sounds and chest wall motion, and beware of the dreaded pneumothorax. You'll see mediastinal shift. The trachea will shift. You'll have absent breath sounds on the one side. The patient's going down the tubes. Put a needle in it and get them to the trauma center. Venous access, we have a bunch of options. Usually our nurses at the Peds Trauma Center can get a peripheral IV in. I'm a big believer in interosseous, though. We put an interosseous and give the kid 20 per kilo, and it's amazing how much easier it is to put an IV in. We've done this on just some medical kids that are sick. You put an interosseous in, you just got to get some volume in them some way to get those veins to fill back with blood so you can get them. Hypotension, you don't need a CAT scan or MRI or MD degree to figure out what the cause of hypotension is. You need a pair of hands and a stethoscope usually. You can listen for breath sounds and diagnose a hemo or pneumothorax. You can look at a kid, and if she looks 9 months pregnant, she's probably got a belly full of blood. A pelvis, you can rock and see if it crackles or they have pain, and so you have a good idea if they have a pelvic fracture, both by your exam and their mechanism. Cardiac, sometimes you can hear the muffled heart sounds, jugular venous distension. You could see external blood loss, and kids bleed a lot. Scalp laceration in a little kid, they can lose a lot of blood. They can lose a unit of blood easy from a big scalp laceration. And then always keep in mind spinal cord injury or spinal shock. Profound hypotension with normal cardia or bradycardia. You start thinking you have a neurologic injury. So all shock is defined as, going back to our first definition, is just inadequate end-tidal oxygenation. And kids have this uncanny ability to just kind of hang in there and maintain, crash and burn. So what we look to do is give them isotonic saline or lactated ringers, 20 per kilo. So it's not adults, it's not cookbook a liter, but it's 20 per kilo. Do that, repeat it once, and then start blood products. Usually in the trauma room, after the 20 per kilo, if they don't respond or transiently respond, and I have a good mechanism, I'm going right to blood and blood products then. I don't wait around. And then start thinking that you're going to the operating room. If they maintain hypotensive and you think it's something correctable, you have to start thinking, am I going to go to angiography? Am I going to go to the operating room? What's our next step? Now the good thing is if you appropriately resuscitate them, they wear their feelings on their sleeves. They pink up. So you can tell as the baby stops crying, pinks up, heart rate slows, they warm up, that you're catching up with them. And the last thing we talked about some is the disability. And the main thing on this is just the documentation, is if there is any neurologic deficit, pupils, movement, things like that, the more it can be placed into the medical record, the more helpful it is to all those involved. There is a pediatric Glasgow Coma scale. There's a pediatric, toddler, and infant Glasgow Coma scale. Again, I've been doing this for a long, long time. I can't remember them. I have them taped up on the wall in the trauma room. There's probably an app that will do it for you, but it's just, I always tell people, I can guess your Glasgow Coma score plus or minus 2 to 3 without looking at a piece of paper. But to truly calculate, I have to look at something that's got it written down. The exposure environment, again, because the kids have that big body surface area, you got to think about warmth right from the time in the field. Put a blanket on them. We cut all their clothes off, but then cover them right back up. It's real easy to just leave them exposed for a long time. So we try to keep them covered, warm. We use Gibby lights, we use bear huggers, we use whatever we need to do. You get in this vicious cycle. They get too cold, they get hypotensive, they get vasoconstrictive and very coagulopathic. So now we get to the fun part. We're going to start talking about injury patterns. So this is Florida, and we're going to talk a little bit about bites and how, was it lions, tigers, and bears, oh my, is that right? Something like that? From the Wizard of Oz. But that's kind of from, where was Dorothy from? Kansas? But we're from Florida, so I thought this was a little more Florida style. That we see sharks, alligators, and pit bulls, oh my. And this makes up a good amount of the bites. And we see a lot of cool bites in kids. It's always pretty dramatic. I thought this was cute. How do you tell if it was an alligator or a crocodile bite? You guys can laugh, come on. The crickets and this was a girl that was, let me get this straight. The next one's from the Withlacoochee, kind of near here. This was another girl that was in the lake at night, and you can kind of see, they have a real distinct bite pattern. The teeth are out here. They kind of bit here, scratch here, and this is the palate. And actually, the next slide shows it better. This was a girl that was in the Withlacoochee. These kids are usually predictable. This doesn't usually just happen. The worst ones we've seen are a girl almost lost her arm. She was in Lake Conway at 10 o'clock at night with her boyfriend, wearing a black long sleeve rash guard shirt with her arm dangling in the water on a boogie board. Yeah, so the alligator's fault? Probably not. These kids were wading in like a really nasty part of the Withlacoochee with their dad. Kid bit down on. Now, we just had one last week, and one of my orthopedic surgeons, he goes in there and makes all this process of measuring the bite mark and just said this was a 6.5-foot alligator, which was a bunch of crap. I'm sure he doesn't know how to do that. This kid, they actually came out from the Department of Wildlife and did measure the palate, so they kind of knew what size gator they were looking for. And you could see it really, again, you have the teeth marks, and here's the palate. And then even that, there's such a crush injury. That's what all the bruise is, even after the fact. They bite down, and then they tend to try to drown their victims is what happens. They bite and then flip them back and forth. We see a fair amount of shark bites. Most of our shark bites are pretty minor. They're usually at the New Smyrna Inlet and it's just the way the break comes in, and that it's a feeding area for the little tiny sharks, and they kind of see little nippers on the feet. This was actually a pretty legit one. This was from Melbourne Beach, and this looked like a little bigger. Again, you see this was the girl that was on the Today Show that had gone to Gatorland and known to stick her fingers into the alligator's nose or something and get it to run away. I don't know. These people always, you want to be on the Today Show, get bit by an alligator. They love it. I mean, the last 3 we've had have all been on the Today Show the next day. So these are just kind of the scratch bite marks of the shark. This is the leg, and they did end up doing okay. She's a great candidate, and she didn't come in. I have another picture later. She should have had a tourniquet. It's a great case to put a tourniquet on somebody. Not going to hurt anything. The first responders probably should have popped a tourniquet on this. This is pit bull bites. These make me sick. These are always beautiful little kids. They get their faces bit. This was one. I mean, you can imagine a little girl who's just pretty much missing her whole cheek. It's gone. It's not like it's a flap we can tack back down. This girl's needed major reconstructive surgery. This kid came in last week, and I just show this to show you how hard these dogs can bite down, their jaw strength. This is her mandible coming down, and then here's her other mandible. And see the offset? That's her lower tooth, that's her lower tooth. And so when it grabbed her face and her jaw, just crushed her mandible. And the amount of, I mean, we see this some really severe trauma sometimes, but you can see the fracture point here, so bottom jaw, and almost overlapping. She had to have extensive craniofacial reconstruction for this. Talk a little bit about penetrating trauma. Penetrating trauma, fortunately, isn't very common in children. We do occasionally see it. This was our typical 14-year-old girl, 4 in the morning, minding her own business in a gas station parking lot. Someone drove by and shot her. Fortunately, we used to have to always run these to angiography. We were able to do an angio-CT. Viola's retirement parties today, y'all, if you didn't see. But she was missing a piece of her artery, and we were able to just go in and just do a little jump graft on it. And she did fine. I got subpoenaed on this case. Do you think I got subpoenaed for the medical care? I got subpoenaed because her family sued the gas station, the poor guy that owned the little liquor store mart there, that he didn't have security to help provide her safety. Now, she didn't ever go in his store and buy anything. She was just hanging out in his parking lot, but they sued him for that. So I'm not a good witness. I'm not very sympathetic. This was a gunshot wound to the mouth. You always hear people say it missed it by 1 inch or got 2 more millimeters and it would have killed him. Usually at the time you're like, yeah, right. It was probably a foot away from anything or would have never hurt anything. This kid was damn lucky. The bullet, you look at this and it looks like it's going right through his spinal cord because your spinal cord's right here. Well, it's just to the side of it. Here's his spinal cord in the middle here, and it lodged right in the edge of his vertebral body. So this kid was fine. He got a little swelling in the back of his mouth and went home, but he truly is one. These are the kids you ask to pick some lotto numbers for you or something because they're truly lucky. This was another one. I had an 11-year-old who was shot in the right neck with a pellet gun. We get kids shot. Don't buy your kids pellet guns. I know you think they're safe, but I can show you a picture of a pellet in about every body part possible in a kid, including brain, heart, lung, everywhere. This kid was shot at 20 feet. Entrance wound just medial to the right sternocleidomastoid muscle. Angio-CT, everything's fine. This is actually a great way to do them. You see the carotid artery and vein, or carotid artery, jugular vein artery. And you march up. You lose it right at the level of the gunshot wound because there's a bunch of artifact. But as you get above it, they're both still there, great flow. So there's no injury to the vessels. We admitted him and watched him. He did great. He had no problems eating, drinking, no fever, anything, except the doctor taking care of him told the mom that he was going to get lead poisoning from the bullet and that we absolutely had to take it out. We don't take bullets out. We don't like taking bullets out. You can cause more harm than good, and they never cause a problem. Almost. I'll show you one at the end if we have time. It's a great case where you probably should have. But anyways, he had this mom so convinced that the kid was getting lead poisoning. So my take on this was, after several phone calls, several office visits, the mom was a pain in the ass. The only thing I learned from this case is I would have the most awesome job in the world taking care of kids if I didn't have to deal with mothers and pediatricians. If I could just take care of them and be done with them. We see a lot of other penetrating trauma. This is a kid riding his BMX bike in the woods. And these are always super dramatic. I'm going to show you a couple of these where he impaled himself on a stick. Medics did a great job. You leave it in, right? They left it in. They usually trim them back so they're not swinging all around. But if you think about, we talk about high velocity gunshot wounds and low velocity gunshot wounds. Well, how fast can a chubby 8-year-old go on a BMX bicycle? I mean, maybe like 15 miles an hour or something. So these are always dramatic because they're such a super low velocity. They almost never hit anything important. As this stick penetrated his skin, stuff just starts diving out of the way and has time to dive out of the way. So usually the thing I worry about in this case is infection. And you got a nasty, dirty, swampy stick sticking out of the kid's groin. So you're going to take this out. It's more dealing with the wound and dealing with the infection afterwards. I forgot to talk about that on the bites too. The bites, it's nice to know what bit the kid because they do have certain antibiotic patterns. Alligators, we learned from our experience, have a really unique bacteria involved with them, and if you don't put them on the right antibiotics, they all get terrible infections. So you do change that up. This was another one, low velocity, chubby kid, bicycle handlebar sticking out of his groin. Medics did a good job. They disconnected the handlebars from the bike and got him to us. And so we take him to the OR, and everybody stands around, and the surgeon has to walk in and just pull it out, and you hope nothing bad happens. So this is it. You pull it out. This is the new charge nurse who never worked in peds before. We made her take her picture with it and give the family the handlebars back. He did fine. This is another penetrating trauma. This is a kid that was running in one of the local department stores with his mom with a hanger in his mouth. As your mom always said, don't run with a hanger in your mouth. And fell in the hanger went in his mouth. So I always said, kids always expect the unexpected. Again, the medics did a great job. They did two things on this kid that I think one was really life-saving. First, they cut the hanger off. You don't want a big long piece because it's going to make the item move further. The other thing is they let the child be transported sitting on the mother's lap. The mother was holding the baby in calm when they got there, so they just put both of them on the stretcher together. And we wheeled them in the trauma room together. We just left them on the medic's stretcher, and we talked to them for a moment. And then all of us went up to the operating room together with the child still on the mother's lap. The whole medic team, everybody, met our anesthesia team there. We masked the kid down, got an LMA in him. So we were able to keep the child calm. This kid starts getting agitated and whatnot. They're going to laryngospasm. They're going to lose their airway. So it's everybody working together as a team. Then I get in there and I couldn't figure out how to get in. Then you start, and then what do I do? And it kind of looks like a fish hook, so I pushed it through, cut it, and then slid it out. And then, again, it didn't hit anything important. We watched him for a day or two. This was an arrow. This was a kid down in Kissimmee. And again, it was low velocity. He was climbing over a fence and slipped and fell on his own arrow. So he wasn't shot. It just was kind of pushed through his neck. So it came in wide awake. Medics, this one they said really had some whip in it. So they cut that off and put him in the chopper. We took him to CAT scan, and again, he got his external jugular vein, which is that little vein you see when you get mad at your kids. It went through that, so we just tied that up, but he missed everything. Super cool family. This was a country boy. This happened down in Kissimmee. His dad was friends with the fire chief, so they just kind of walked from the woods right to the fire station where the helicopter met him. After I took this out, the mom goes, gosh, we're leaving tomorrow to go to the Keys fishing. Do we really need to come back? I said, just send me a picture of him. And this is him. Now, someone just told me that was at my talk on Saturday, this kid's like a famous archer now and or he's a fisherman, or he does some sports show on TV. But he's still got my cool scar on his neck. These are some other penetrating traumas. The one on the right's kind of gross. It's a pickle, or left. It's a pickle. We wanted to take the kid to the operating room, take it out. It's a 14-year-old boy. Dad said, no, he got it in there. He can figure out how to get it out. So we gave him 24 hours, no questions asked. It was out the next day. I don't know how. This was just some kid running and impaled himself on. I can't remember what this was. It almost looks like an artificial knee go bad, but it was something he impaled himself on. It just kind of went up through his knee. This was one just recently. This poor kid was just leaning over this fence in their condos and fell on this. And this is his neck, and it tracked right up to his ear. Now, how he lifted himself off this, I have no idea, but I'm glad he did, because it saved myself and the medics a lot. The medics probably would have had to cut this, bring it in, stick it on his neck. Then I would have all the angst of pulling him out. We took him and did an angio-CT and sewed him up in the ER and sent him home. So it's fortunate. It tracked out towards his ear, not medial. Again, lucky how you fall. It tracks up medial towards your brainstem and your carotid and stuff. You're going to have more injuries. I just have to touch on this briefly. This is always super frustrating. It's non-accidental trauma. We as healthcare givers need to be very cognizant of this. It's our job as a liaison or as an advocate for children is if you suspect child abuse, say something. I've got about zero tolerance for this. If I even halfway suspect it, I'm calling them in. And I'll tell the parents, I go, we see a lot of crazy stuff. This is a little suspicious. Just tell them the truth about what happened. We see a lot of funny burn patterns and whatnot. But for every time I've done that, I also have the social workers or the DCF people come back and say, you know what? This is the third time this has happened to this kid or one of their siblings. I hate testifying in court cases. I hate drunk drivers. I hate dealing with all that. I love testifying in these kind of cases. You don't want me. I'm a hostile witness because this ticks me off. And when I suspect child abuse, I write the best consult note you ever saw. I'm going to document the hell out of it, of exactly why I think it's child abuse. You don't fall off a chair and have a bite mark on your inner thigh. That's wrong. And I'm going to point it out. And I go to the depot, and usually the cases end right there. But you got to be an advocate. You got to stand up. If it doesn't sound right, if you're not comfortable, tell the doctor when you get there. I base it a lot on the medics. The house was a mess. It was filthy. That might be the little bit of information I need to report it. Or, they waited a long time to call us. This happened 2 hours ago. The burn that happened yesterday. If the child's in the care of a non-parental custodian, i.e. mom's boyfriend, really put up your antennas, because that's usually the scenario. These are the unfortunate things we see. This was a bad just beat to the face, depressed skull fracture hit with an inanimate object. Just, these are fingerprints. And this is the kind of stuff, your documentation. What you start looking at bruise patterns. First off, that's not a new bruise. That didn't just happen. A new bruise, acute bruise is really black and blue and whatnot. These are kind of that, it's washed out. Kind of like the alligator bite a week later. These are washed out. So there's the timing of the bruise pattern. These are old rib fractures that are healing. You kind of get the callus around the ribs. So these rib fractures didn't happen today. They happened a week, 2 weeks ago. So one thing we do for prevention is if we can't treat the devastating injury of the event, we can prevent the event. So pre-event, crosswalk smoke alarms. We can alter the event, so take away the force of the injury. Bicycle helmet, car seats, airbags. And then post-events is to have a great EMS community, a dedicated trauma EMS system within the state to take care of these kids. I think our next big threat, we spend a lot of time dealing with drunk driving, I think is texting and driving now. I run, I bicycle, I'm scared. Everybody's on their cell phone. I don't know how you guys do it when you're going lights and siren. I was sitting there at the light the other night. Here comes Orange County Rescue, lights and siren. You see them coming from, and there's just some guy on his cell phone just driving right down. They have to stop, go around him. So I think my kids are really good about the drinking and driving. It's people more my age that still drink and drive. The kids all Uber and Lyft. But you got to be wary of this. I'm going to stop here. I've got a couple more little cute scenarios, but does anybody have any questions up to now? This is me post-shift tomorrow. Maybe later tonight. So injury is the leading cause of death in children. Kids are a little bit unique, and there's some minor nuances. Try to get them to a peds trauma center or to a local trauma center that can move them onto the trauma center. You guys are kind of in the middle between two, so I think Lakeland does a good job of getting the kids and then getting them onto the appropriate places to go, and just improve ability to prevent. I hope you had fun and learned something and just expressed some of my passion for trauma. Shout out for Stop the Bleed that Dr. Hunter spoke about. We're really pushing this in our community. We have a community class every Tuesday night that a bunch of the docs help teach. It's a 2-hour course. I would think a medic should be able to get through the course in about 15 minutes, half hour at the most. It's a deck of slides, and they show you how to hold pressure, pack a wound, and put a tourniquet on. Don't put the tourniquet around the neck. If your head's bleeding or your shoulder's bleeding, you can't put a tourniquet around it. Just simple stuff like that. We had a tourniquet. This was a kid from I-4 the other day. The usual 2 cars, fender bender, get out. They're talking between the cars, and another car just roars up and slams into them. Every medic, tow truck drivers, worst nightmare. You stop to help, and then you get nailed. This kid, they did a great job. He had a really devastating leg injury. This was about 11:15. Put the tourniquet on, and Mark, when it went up, he came in, we let it down, and guess what? It filled right up with blood, so we just torqued it down and called our orthopedic guys, and they took him right up to the operating room. We were able to save his leg. His leg was hanging. I thought it was going to be an amputation, but he was neurovascularly intact, and they were able to save it. 2 quick crazy cases. This is a 12-year-old kid that was sucking on his water bottle, getting his tongue stuck in it and making the thwack sound when you pull it out. But he sucked one time too hard and got his tongue stuck in it. And so the medics got called. So the medics did a good job. They did a couple things in the field. They drilled a hole in it first to see if they could break the vacuum. Then they cut the end of it off and still couldn't get it off. So I was on call, so I had the bright idea. I'm going to use hypertonic saline and just pour hypertonic saline on his tongue. The swelling will go down and it'll pull right off. No luck. So we took the kid to the operating room, and this is me trying to hold the kid down. This is one of our new anesthesiologists, and she had the bright idea that she was going to wake, nasotracheally intubate a 12-year-old boy with a bottle stuck on his tongue. This kid was strong. I mean, there was no way. So we're fighting. And sometimes when you're doing this, it's important to listen to everybody in the room. Because someone in the room just said LMA, and we go, oh, stop. You're pulling this bottle. You're looking at his vocal cords. He's just screaming. Put an LMA in. Got it beyond this area of his tongue. Everybody chilled. Gave him a little propofol. Things settled down, and then we got him intubated. But I think it was like one of the anesthesia techs or something. It wasn't one of the lead of anesthesia was in there, the trauma surgeons, everybody. But you got to listen up and have that culture where everybody has input and has a good idea. If you ever are faced with these, I hope you're not. The cans are really thin. You can cut them with your trauma shears. Some go, oh, this is easy, until you get right to the top. There's a really thick ring. And we had a ring. We should have used a ring remover, like you take a ring off. But the new ones are electric, and we didn't have the piece on it. So I trashed about 3 dental drills, taking it off. This kid's tongue was so swollen. He stayed intubated for 2 days because his tongue was just sticking out of his mouth. But he did fine. This is my last one. I'm going to stop after this. This was a very cool case. And this was, I think this kid might have come out of Polk County. 10-year-old male, OSH, outside hospital. Now, his mother was incarcerated. Now, I'm not impugning anybody from Polk County about that, but mother's in the jail, lives with his aunt, wrestling with his brother, and they go to the ER. Oh, both his parents were in jail. Imagine that. And he was fine, but he just had this little mark on his chest and said he was wrestling, he just had some chest pain. So they got an x-ray, and on x-ray, he's got a needle in his chest and a little pneumothorax. So I'm on call, I got like 5 cases. I go, I'll get to it. This is no big deal. It's just the needle's in his chest. They actually got a CT scan, and you can see the needle coming through. See the pneumothorax is black. This is lung tissue. I go, I'll just cut down and pull it out. Not a big deal. Bring fluoroscopy in the room. So I do my cases. I meet the kid. He's starving. I go, I promise you, man, it's going to take 10 minutes. You'll be eating lunch. Take him to the OR, and what we do is we bring the fluoroscopy machine in, and then we put a hemostat over to try to decide where to reach in and grab it. So I kind of line it up, and I go, wait a second, it's moving. And so I cut down on it, I try to grab it, and anesthesia goes, we just had a bad arrhythmia. Like, he went into VTAC when you did that. I'm like, what are you talking about? So I started doing it, and it was moving with his heart. And I go, I think it might be in his heart. So I stopped and got a transesophageal echo. And not only was it in his heart, it was in his ventricle, and the tip of the needle was right at the base of something called your chordae tendineae. It's what supports your valve. And it was going back and forth right across the tip of the needle. So I call my cardiac guy in. I expect him to just light into me for calling him on a Saturday afternoon. He was so excited. Because he's one of these go-getters. He's always like, if you ever need my help, I'll help you do anything. And we're going, you're a heart surgeon. You're not of any help to us ever in trauma. So I call him. He came right in. We moved him to the heart room. He had his whole team there. So we ended up doing a median sternotomy. And we got in there. And this shows you where it was in the heart. And we were just going to kind of reach in and grab it and pull it out. Well, he reaches in to pull it out and takes his hemostat out, misses it, and blood starts squirting out of his ventricle. So we got to fix the hole in his ventricle. And then we went on bypass and opened his atrium, and here's the needle sticking in the heart. There's a couple of them here. And this is right up against the base of the valve. And there's the valve. And then we try to figure out, well, like, how did this happen? Is this something bad? Did someone do this on purpose to the kid? It turned out the aunt was this sweet woman that took these poor orphan boys in. She was trying to make comforters out of sheets and had them all pinned and hadn't gotten around to sewing them, and they were wrestling on them. So it truly wasn't there was no malice or anything. I felt really bad for the kid. This is his atrium all sewn up. This is his post-op chest x-ray. So I felt bad because I told him he'd be eating lunch in like 10 minutes, and this is like 3 hours later, and he's got a chest tube and sternal wires, and he wakes up in the CV ICU, but no. He's got a great story to tell. So thank you guys very much. It's an honor to be here, and I can answer any questions.